Keys, and I will be presenting topic 62, H1N1, USA and worldwide 2009 to 2010. First of all, let's discuss what is H1N1. So influenza viruses have surface proteins called hemagglutinin, represented by H, and neuraminidase, represented by N. There are 18 different hemagglutinin subtypes and 11 different neuraminidase subtypes. The 2009 pandemic was caused by an influenza A virus with subtype 1 hemagglutinin and subtype 1 neuraminidase, therefore H1N1. What causes a pandemic influenza? So antigenic shift occurs when there is a major change in the hemagglutinin and/or neuraminidase proteins. The shift can happen when an influenza virus from animals develops the ability to infect humans. As these viruses are new to the human immune system, most people will have no immunity. This occurred in 2009, where the influenza viruses mixed genes from pigs, birds, and humans to create a novel H1N1 virus, which was able to infect humans and cause human-to-human transmission. In February 2009, the first cases appeared in Mexico, but weren't confirmed until later. March 2009, cases appear in California, where the causal influenza A subtype was not able to be identified. The samples were sent to the CDC for further analysis. In April 2009, the first laboratory-confirmed case of novel 2009 H1N1 influenza was made. The CDC reports this to the World Health Organization and is shared with Mexico. Samples are sent from Mexico and are genetically identical to the samples from California. Gene sequencing is completed and uploaded to the publicly accessible International Influenza Database. The USA declares a nationwide emergency and the CDC begins releasing 25% of the national stockpile supplies that could be used to contain and treat influenza. On the 25th of April 2009, the World Health Organization declares a public health emergency of international concern with the Public Health Alert Phase Level 3. On the 27th of April 2009, there are confirmed cases which appear in Canada, Spain, and the United Kingdom, with suspected cases in several other countries. The World Health Organization raises the pandemic alert to Phase 4. On the 29th of April 2009, there are now 148 cases confirmed in 9 countries. The World Health Organization raises the level of influenza pandemic alert to Phase 5, signalling that a pandemic was imminent and requesting all countries to immediately activate their pandemic preparedness plans. On the 11th of June 2009, there are now 73 countries with reported laboratory-confirmed cases, and the World Health Organization declares a pandemic and raises the pandemic alert level to Phase 6. In September 2009, the H1N1 virus has become the predominant circulating virus worldwide. In September 2009, the FDA approves 4 H1N1 vaccines, and the European Medicines Agency approves 2. In October 2009, vaccinations begin in the USA and European countries. By November 2009, there are more than 199 countries which have laboratory-confirmed cases, and approximately 65 million people have been vaccinated. On the 11th of August 2010, the World Health Organization announced the end of the 2009 H1N1 influenza pandemic. However, this virus continues to circulate today. Impact in the USA and worldwide. The USA estimates they had 60.8 million cases with approximately 274,000 hospitalizations and 12,500 deaths. Worldwide, it's estimated around 151,000 to 575,000 deaths occurred, with 80% of deaths occurring in those under the age of 65. Now, this is different compared to seasonal influenza, where we see the largest morbidity in those over the age of 65. This is likely due to older persons having some cross-immunity from prior exposure to antigenically similar H1N1 viruses in the past, which offers them some protection against the 2009 H1N1 virus. This is a table of the estimated hospitalizations and mortality rates in the USA based on age. So as you can see, those aged 0 to 17 were 7 times more likely to be hospitalised due to H1N1 than seasonal influenza, and 8 times more likely to die, while those aged 18 to 64 were 4 times more likely to be hospitalised and 12 times more likely to die. This is in comparison to those over the age of 65, who were actually 75% less likely to be hospitalised from H1N1 and 81% less likely to die from H1N1 than seasonal influenza. So the management strategies that were used. So the International Health Regulations was designed to prevent the international spread of infectious diseases while avoiding interference with international traffic and trade. It was shaped by the 2003 SARS outbreak. It delegated responsibilities of countries and the leadership role of the World Health Organization in declaring and managing a public health emergency of international concern. It established systematic approaches to surveillance and early warning systems. Unfortunately, many countries did not have the capacity to comply with the international health regulations. Communication was another important management strategy, with each member state establishing national offices that would be responsible for rapid collection and dissemination of emerging data and guidance. The World Health Organization's Global Influenza Surveillance Network was able to detect, identify, and characterize the virus in a timely manner and monitored the course of the pandemic. However, not all countries had the epidemiological or laboratory capacity to meet the surveillance requirements of the World Health Organization. Another management strategy was the use of antiviral medication. The World Health Organization was able to distribute more than 3 million courses of antiviral medication to 72 countries. School closures were also a management strategy, and given the higher morbidity and mortality rates in younger people, vaccination was another strategy that was used. However, despite the rapid development of a vaccine, and there were 78 million doses provided to 77 countries, the vaccine was not distributed in a timely manner. There could be a couple of reasons for this. The first was the reliance on viral egg cultures to produce vaccine. This may change with future flu pandemics with the development of mRNA vaccines during COVID. The second was the unequal distribution of vaccines among countries, with wealthier countries and manufacturers of vaccines having different willingness to donate vaccines to poorer countries. The impact of H1N1 in a prison environment. Prisons are high-risk environments for infectious disease outbreaks. There's high-density population, overcrowding. Some facilities have dormitory-style accommodation, poor ventilation, the inability of prisoners to socially distance, constant movements between facilities and into and out of the community. Many of prisoners also have underlying comorbidities. There are higher rates of chronic disease, tobacco smoking, high-risk alcohol use, and illicit drug use compared to the general population, which puts them in increased risk of morbidity from influenza. This is a photo of a correctional centre in New South Wales, Australia. It's called Hunter Correctional Facility, and it's at Cessnock. Now, as you can see, it's a dormitory style accommodation, and up to 25 people can live in this accommodation. So you can imagine if influenza was to penetrate this kind of environment, it would spread rapidly. So what was the impact of H1N1 in a prison environment? So in the US, they conducted a national survey of prisons, and they had 47 prisons respond back. Of those, 79% had confirmed or suspected H1N1 activity, 53% had had an outbreak, 43% had confirmed or suspected cases among staff, 22% had hospitalisation of prisoners. There was a total of 7 prisoner deaths and no deaths among staff. So what are some of the ways we can manage H1N1 in a prison setting? So one recommendation would be screening for influenza-like illness. So to prevent a pandemic in the community entering a correctional facility, we need to screen both staff, visitors, and prisoners for influenza-like illness. So for staff and visitors, we would screen them on entry into the facility. We would also advise staff to actively monitor and encourage reporting of influenza-like illness. However, we would exclude symptomatic staff and visitors from the facility for 7 days from symptom onset and until at least 24 hours post-symptom resolution. Now, unfortunately, some staff may withhold symptoms for fear of loss of income if they do not have access to sick leave or pandemic leave. Now, this was a problem in Potter et al.'s survey, where they did find that 43% of prisons in the US had confirmed or suspected cases among staff. So it's important to screen for influenza-like illness. It's also important to screen patients, so patients on entry when they first come into prison, to prevent them introducing the virus into the facility, and also on transfer to and from other facilities to prevent the spread to another location. Prisoners should also be actively encouraged to report influenza-like illness, but again, they may withhold symptoms for fear of isolation or retaliation from other prisoners, as isolation will occur for those prisoners who are symptomatic for a minimum of 7 days, and again until at least 24 hours post-symptom resolution. Now, during the H1N1 pandemic in New South Wales, they did a survey testing those prisoners with influenza-like illness from June to August 2019, and found that 43% of those prisoners were positive for H1N1, while the other 10% were positive for seasonal influenza. So again, very important to identify people with influenza-like illness. Second recommendation would be the isolation of confirmed or suspected cases. Now, this can be challenging in a prison setting for a number of reasons. As you saw from the Hunter Correctional Facility, it's hard to isolate people who live in dormitory style accommodation. And if prisons are at or over capacity, there may be limited availability of cells to provide isolation. Some cells also do not have showers, and denying someone a shower for 7 days can lead to riots and prisoners burning cells in protest. People in prison also have higher rates of mental illness, self-harm, and suicide, and isolation can have a detrimental effect on mental health. There's also the care of patients in isolation to consider. Now, in prison, healthcare workers cannot see a patient without the permission of security staff, which may not be granted if there's a risk of, if security deems it unsafe or if there's inadequate staff. Prisoners can also not be transferred to ED unless security arranges that, which again could be an issue if there's limited security staff due to a pandemic, which is called high staff sickness. And also, not all centres have 24-hour nursing, so then it would fall onto the security staff to manage patients in isolation. So very difficult to manage infectious disease in a prison setting. Thank you. That's the end of my presentation, and I will just go through the references. Thank you very much.